capsule and corona radiata, and occasionally the pons. Again, one of those tiny little perforators off the basilar artery occludes. And these are your lacunar stroke syndromes. Or if they just, one of the penetrators that comes off the PCA infarcts the thalamus, they'll have just numbness on one side of their body, face, arm, and leg. Whereas in hemispheric strokes, remember we have ACA and MCA. ACA supplies the leg, MCA supplies the arm, the face, the tongue, all these things. They'll commonly just present with more arm and upper extremity weakness rather than leg weakness, unless they're having a very big stroke. That was funny. So code stroke and the ED, so somebody presents with abrupt symptoms, less than 6 hours of onset. You need to act fast. So in RER, when patients come in as a code stroke on the ambulance, they go straight to CAT scan. The ER resident or physician will briefly stop the paramedics and get a very quick history, what's going on, briefly examine the patient, but they basically go straight to CAT scan. The paramedics check the glucose. The most important thing you need to find out is last time seen normal. So time of onset equals last seen normal. If somebody's having a right hemispheric stroke, you can't usually trust that patient, because especially if they're neglectful and they don't think anything's going on. But you need to know last seen normal. That's usually the biggest holdup in giving these patients the treatment. So check glucose, get a CAT scan, make sure. Are you getting that CAT scan to diagnose the stroke? Or why do we do the CAT scan? Check for bleeding, that's correct. A CAT scan early on in stroke, ischemic stroke, should be negative, meaning they should have acute ischemia. Now you may see an old stroke or something else, but if truly they're presenting within 3 hours of symptoms, the CAT scan, if they don't have a hemorrhage, should be normal. It takes about 6 to 8 hours for a stroke to show up on a CAT scan. Typically you get an EKG, you'll draw Rainbow Labs, CBC, a BMP, check their coagulation, find out if they're on any anticoagulants, get the NIH stroke scale score. So doing a code stroke in the ER requires a lot of teamwork with the providers and the nurses and everybody involved. The techs getting the blood work, the techs doing the CAT scans, because it's all about time. And then you want to be sure that there's no contraindications to giving the clot busting medicine. Blood pressure. The blood pressure should be high during a stroke. If somebody's presenting with a stroke and their blood pressure, or you initially think they're presenting with a stroke, and then you see their blood pressure is 90 over 40, you got to take a step back and ask, what's going on here, because of the CNS control of blood pressure should be high. So things that would present with low blood pressure are, patients that are extremely dehydrated and having a stroke. But even those ones usually still have high blood pressure, but they're septic. So do they have endocarditis actually? And they've just embolized to their brain as well, because you don't give those people TPA. So you kind of halt if their blood pressure isn't high. So again, you don't want to drop the pressure too low because it damages the penumbra. So that's the area of ischemia outside the core infarct. So to give IV TPA, the blood pressure needs to be below 185 over 110, but it only has to be slightly below that. If they're not a TPA candidate, then you let the blood pressure run high unless it gets above 220 over 120. Nicardipine is the first line treatment. That's a calcium channel blocker. Labetalol is a beta blocker with alpha blockade as well. that is commonly used in ERs, because not all ERs will have nicardipine. You do want to avoid rapid-acting medications, you know, hydralazine, nitroprusside. You want to avoid those because those rapidly drop blood pressure, and you don't want that in stroke. And nicardipine is easy to titrate on and off. So after they've given TPA, note the goal by the standards made by the American Stroke and American Heart Association is 180 over 105. So that's your goal after TPA. In order to give TPA, it's 185 over 110. That's always confusing and annoying. TPA is Alteplase, tissue plasminogen activator. You give it typically within 3 to 4.5 hours of last seen normal. Door to needle time, you try to give the medication within an hour, though now the American Stroke Association has moved to 45 minutes, because really the only thing you need is a last seen normal, a CAT scan, and a glucose. And then a neurological deficit, you know, disability. So if a guitarist in a band presents with sudden onset of right hand weakness, is that disabling? He's right-handed, and he plays the guitar for a living. Is that disabling to him? Yeah. Would that be disabling to an 89-year-old who lives in a nursing home? No. So it's always the context too, because you know the guidelines say, okay, their NIH stroke scale score has to be greater than 4. Well, if a heart surgeon presents with a stroke and has just isolated hand weakness, you don't have many options besides say, oh yeah, you're having a stroke. You can't do anything because you're not severe enough. So no, you don't not treat people just because of that. You kind of, each person you treat as an individual patient as well. So if somebody presents with sudden onset of right hand weakness, you know, that's not carpal tunnel. Carpal tunnel doesn't cause sudden onset hand weakness. That's usually going to be a stroke.
You said when they show up you need a CT, you need to check their glucose, and then what was the last one?
CT, check their glucose, and last known normal. The most important thing.
Okay, and on the previous slide you had the EKG is needed prior to giving TPA?
That's not true anymore. I didn't update that, but that's not true anymore. Maybe from a test standpoint it is, I don't know. I would defer that to your teacher, but from a treatment standpoint, they've redone the guidelines to where basically all you need is a glucose, last seen normal, a neurological deficit, and a CAT scan without bleeding. Because TPA, we've discovered, is very safe to give, even though, you know, again, there is risk of bleeding because you're giving a powerful blood thinner, and ischemic strokes can transform into hemorrhagic strokes. So about 3% of people will have a symptomatic hemorrhage from TPA, and about 6% of people will have some hemorrhage, but you know, only half of those will have increased disability from it. So again, you need a CAT scan, a glucose, so you're looking for hypoglycemia, you know, like a glucose of 20. And then you treat it, and if they're no better after about 10-15 minutes, then you would still go ahead and give TPA. Now, the other things you need to know is you need to know the other contraindications. If somebody is on Xarelto or Eliquis or Coumadin and their INR is greater than 1.7, that obviously, if they're on Coumadin, you need an INR before you can give the TPA. But if they're not on Coumadin, you don't have to worry about that. Okay. So TPA decreases disability risk by 30%. That's why we give it. And it used to be the only treatment we had for acute strokes. So this is a good thing to know. There are more lawsuits against people not giving TPA than there are for them giving it and the patient has a bad outcome. So, because it is the standard of care. But there are still many ER doctors that oppose and are will not give patients IV TPA. In this state, actually, there are some that will not. So TPA dose, you give 10% of the bolus, 0.9 milligrams per kilogram, with 90 milligrams as the maximum dose. It actually comes in a 100 milligram vial, so you have to syringe it out. Less than 3 hours is FDA approved. 3 to 4.5 is accepted as a standard of care per the American Heart, American Stroke Association, but is not FDA approved. So usually you just make family or the decision maker, if the patient's able to be the decision maker, you make them aware of that. But it shouldn't stop you from giving it. So if they are in the 3 to 4.5 hour stroke window, if their NIH stroke scale is greater than 25, typically we're going to discuss that maybe the risks of giving it outweigh the benefits because the stroke size is so large. And the larger the stroke and the longer it's been there, the more likely they are to have a hemorrhagic transformation. If they're taking warfarin or if they're on any blood thinners, you won't give it. And if they're on blood thinners in the 3 hours, you can't give it if they've had them within 48 hours. So the Eliquis, the Xarelto, any of those new blood thinners that people are on for AFib. So it used to be those patients that were on anticoagulation were not a candidate for anything, but now we have what's called intra-arterial treatment, where specially trained, usually neuro interventionalist, which is usually a radiologist, sometimes a neurologist, is able to go in through the groin and thread a catheter up and suck out the clot, or sometimes, but not as common anymore, administer intra-arterial TPA, so TPA directly to the clot. So here's a clinical case. This is a 77-year-old right-handed male who presented with trouble walking while he was talking with a client. He was a lawyer. This seemed to come on suddenly, but maybe had been going on longer than that. He just wasn't sure. He had been having some neck pain, but that had been a chronic problem for him. His past medical history is he is obese, he has hypertension, he has a history of coronary artery disease and high cholesterol. He denied having any numbness or focal weakness, but later on thought his legs were weak and symptoms were worse when he was standing upright. So overall, fairly nonspecific, but the trouble walking is certainly concerning. His neurological exam was completely normal when we first saw him. We actually did orthostatic vital signs. There was no significant orthostasis. That is a common presentation of orthostatic hypotension. Is their legs feel heavy when they stand up for too long. So we were going to MRI his brain and as well as his cervical spine. He's having the neck pain, and given his age, he's likely to have some degenerative changes in the spine, and chronic spinal cord compression can present with nonspecific gait disorder. So that's the reasoning behind the cervical spine. After we left the room, the patient got up to go to the restroom, and we had been gone for about 10 minutes, and we're going on our rounds. And when he got up from the restroom, he developed a sudden onset of left hemiparesis. He was in the hospital, severe dysarthria, a left central seventh. So what do I mean by a central seventh? So what's the difference between a Bell's palsy and facial weakness from a stroke? So upper and lower face. So raising the eyebrows and the wrinkling, yes. And then is closing your eye real tight, is that upper or lower face? Upper, yep, she pointed up. So that's right, because it's the orbicularis oculi. So that's actually the earliest finding in Bell's palsy, is they'll have weakness, they'll have the drooping. Their forehead wrinkles well, and you think it looks normal. They don't have slurred speech. And so you say, close your eyes real tight, and they close their eyes, and you can easily open their eyelid. And you can try and open a baby's eyelid if they're crying and you can't do it. Now, people can have functional and just let you open it, but you'll see the color. Usually, if they're giving good effort, you'll only see the whites of their eyes when you overcome them. And then if you really pay attention and watch them blink, they'll blink much slower with a Bell's palsy. So, he had a right gaze preference, and obviously this isn't a Bell's palsy. So he was looking to the right, left hemiparesis, weakness, dysarthria, and then he had weakness in his right lower extremity. The nurse called a BAT, which is kind of an inpatient code stroke that nurses can call, anybody in the hospital can call it actually. And then, so a team of resident and nurses respond to these. His NIH stroke scale had noted to be changed from 10. He was just seen by the neurologist, and his neurological examination was normal. So a CAT scan was performed, and he has some subtle, very subtle changes in the right hemisphere. Right here, there's a little bit of a hypodensity. When you're looking at a CAT scan, water shows up dark, black. Have y'all had radiology yet? A little bit? No? You get it during each section, or? Okay. So this is the front, this is right, this is left. It's like you're looking at somebody, they're laying in front of you. The white is the skull. So CAT scans measure density. So the brighter something is, the more calcified it is. Blood shows up bright white. So you're kind of looking at gray-white differentiation. There's a very subtle change that this was actually the CAT scan performed earlier, and we actually missed this. So it's very subtle, just some subtle changes here. Okay. So you're kind of just looking at shades of gray, basically. So given now, knowing his history prior, he had symptoms for several days. He has ischemic area that's recent in the medial temporal lobe on his CAT scan. It wasn't really safe to give him IV TPA, even though you can make arguments that you could have restarted his time at the time when his symptoms came on again. But, recent stroke is a contraindication to IV TPA. So we elected to not IV TPA him, but to obtain further workup. We suspected, given he was having the same symptoms recur over and over again, kind of stuttering, that this was a vascular problem, meaning he had an area of stenosis. He was kind of having the same symptoms. So, a stroke that comes from the heart isn't going to go to the same area of the brain every time. So, given he was having the same symptoms, we suspected he had either a thrombus in his MCA or a very tight carotid stenosis. So we ordered a stat CT angiogram of the head and neck, and it showed, so here's the common carotid coming off the, here's the aorta, brachiocephalic, and then here is where his right internal carotid should be coming, and it occludes. You can see the taper here. So he had acute occlusion of that. We don't have neurointervention at our hospital, but Integris Baptist does on Northwest Expressway. So we contacted Dr. Fortes and presented the case to him. And he was given it, and he decided to take him and transfer for potential embolectomy. They actually even gave him an aspect score of 10. So that's a grading system of how much ischemia you think is on the CAT scan. So this is the thrombus. This is the actual thrombus that was pulled out of the patient. Here's his pre-embolectomy arteriogram. See how it tapers there. So here's the external carotid. See these are all branches off the external carotid. Remember, the external carotid supplies the face and the neck. And then this is the artery going to the thyroid here. So he had a complete occlusion. He was able to pull out the clot, doing an embolectomy. The patient did have residual stenosis, so his NIH stroke scale score went from 10 to a 1. In 1 week post-embolectomy, they felt he was asymptomatic. And then a few weeks later, he had a carotid endarterectomy for the residual stenosis. So Dr. Fortes decided not to stent him, but to just pull out the acute clot. So these are the endovascular guidelines for acute ischemic stroke. Age greater than 18, pre-stroke disability of 0 to 1. So, if somebody's in the nursing home, is bedbound, you're not going to do this aggressive therapy on them. The NIH stroke scale score needs to be greater than 6. So 666 is kind of what you remember. Their aspect score, which is something that the radiologist will do, should be greater than 6. This is the amount of ischemia evident on the CAT scan. And then the needle needs to be poised above the groin by 6 hours. And then you want to treat people that have a large artery occlusion on CT angiogram. So either the distal ICA or a proximal MCA. So this is just our transfer protocol. I'm not going to go through this. But if you're at an outside hospital, somebody presents with abrupt onset of aphasia, a gaze preference, left hemiparesis, their NIH stroke scale score is going to be greater than 6. So you'll want to, at the very beginning, contacting the neurologist that is on call for your hospital, or in a hospital that you have an agreement with. If you're in rural Oklahoma, we do have a program called Telestroke that a lot of hospitals have. I think we have 18 satellite hospitals that we do what's called Telestroke for. So meaning these smaller hospitals in small towns that don't have neurology coverage, their ER doctors have direct access to contact the neurologist on call for it immediately. And they'll help in this decision making. So while the patient's in the hospital, you're going to provide supportive care, make sure that you keep them euvolemic. You allow the blood pressure to run high. After a few days, you'll start a low-dose ACE inhibitor or angiotensin receptor blocker if they're able to tolerate it. A high-dose statin medication, Lipitor, Crestor, those kinds of meds. And then you want to keep their blood glucose less than 150. And you want to prevent complications such as DVT, aspiration, UTIs, and treat constipation or prophylactically treat it. How you prevent aspiration is you have speech therapy evaluate these patients before you allow them to have a diet, especially if they have slurred speech or facial weakness. You treat the acute event with either IV TPA or thrombectomy. Then you have rehab services evaluate the patient. Then you have case workers and case managers that help with outpatient planning, because obviously strokes can be quite devastating. And then you optimize their vascular risk factors, high blood pressure, cholesterol, diabetes, talk about alcohol cessation, smoking cessation, and you decide what the cause of their stroke is. Is it due to artery stenosis, like our gentleman, or atherosclerosis? Is it a small vessel stroke? Is it cardioembolic? Do they have an underlying hypercoagulable disorder? Are you unsure of the cause? And so you work these patients up. You get MRI scans. You look at their vasculature with CTA or sometimes a carotid ultrasound. Echo to look at their heart. Sometimes you need a TEE because we have ribs that kind of impair our view, and a lot of patients have COPD. The lungs impair the view of the heart through the echo, so you want to make sure that they don't have a lot of plaque in their aorta or a clot in the left atrium, or they have a severe valve problem. And then you monitor them on telemetry to look for any AFib, because AFib is a very common cause of stroke. And then patients that you're not sure about, and they're young, you order a hypercoagulable profile. All right, some stroke mimics. So if somebody has a seizure disorder and nobody saw the seizure, but then after the seizure they have what's called Todd's paralysis, and if they have a hemiparesis, that can mimic a stroke. Hypoglycemia, migraine is a common mimic of stroke. Press. Sometimes patients with previous stroke come in with worsening of the same stroke symptoms that they had previously, meaning they had a right hemispheric stroke, and they just look much more worse than their baseline. And a lot of times that's due to a UTI, a pneumonia, they have electrolyte problems, mass lesions. Obviously you don't want to give TPA to a brain tumor. Subarachnoid hemorrhage, again, those usually present very differently. Sudden onset worst headache of their life. Peripheral vestibulopathies, which we talked about vestibular neuritis and how it can look very similar to a cerebellar stroke. And then conversion disorders. So things that aren't really TIAs, confusion, disorientation. I felt foggy for 5 minutes. That's not really a stroke or TIA. Syncope, or like near syncope, meaning they're transiently lightheaded. TGA, transient global amnesia, which is an interesting condition that we see about 4 or 5 times a year, where patients, healthy patients, sometimes unhealthy patients, come in and their family says they're just confused and they just keep on asking me the same questions over and over again, and they keep on and they just can't form new memories. It's transient, it goes away, it's a benign condition. It's felt to be kind of a migraine syndrome, but nobody really knows what causes it. Vertigo. Isolated vertigo can sometimes be a stroke, but more commonly it's VPPV or vestibular neuritis. So you have to ask those other questions. Do they have slurred speech? Do they have double vision? Do they have numbness or tingling, loss of feeling on one side of their body? So this is a patient that had a TIA or a clinical TIA, and this is an MRI scan. This side is T2 imaging, and this is what we call diffusion weighted. This is the most sensitive testing for a stroke. On MRI, it's a specific sequence. And so this bright white spot is the area of stroke and permanent damage. So one thing in the ER, sometimes in the ER you practice veterinary medicine, you don't have much history because there's no family and the patient can't really give you the history. And so a thing to look at, especially in elderly patients, is they're laying in front of you on the table, and you notice one foot is sitting upright and the other is kind of externally rotated. So things that can cause an externally rotated foot are a prior hip surgery, so they've had a hip fracture and they had to repair that, or weakness. So the patient's weakened that leg. So if somebody's confused, but really once you get in there and examine them, they're aphasic, and you notice their right foot is externally rotated, they've probably had a stroke in their left hemisphere. So that's a nice thing to look at. And then you check their toes, for the Babinski. It's commonly people with central neurological problems will have a upgoing toe. But in acute stroke, that's not always evident. It will be evident usually later on, but it may not be evident during an acute event. So 45-year-old female was at a grocery store with her daughter when she suddenly slumped over and became nonverbal at 4:05 p.m. Her daughter called 911 immediately. The patient arrived at the ER at 4:20 and was immediately noted to have global aphasia and severe right hemiparesis. The ER called the stroke team at 4:30 while the patient was taken to CT imaging. So last known normal was 4:05, right? Because the daughter witnessed it, the onset. So right now we're about 25 minutes into the stroke. At 4:50, CT scan had been performed. No hemorrhage or clear hypodensity was seen. Her blood pressure is 160/85. Her general medical exam is normal. Her night stroke scale score is 18 because of her aphasia and right hemiparesis. Her finger stick blood sugar was 114. EKG was normal sinus rhythm. No ST changes. CDC was negative. Coags were pending. It was confirmed by the daughter that the patient was not taking warfarin, heparin, Lovenox, or any other anticoagulants. So, right now, is this patient a candidate for TPA? Right? She's within the window. It doesn't seem to be an obvious contraindication based on the information we have. Her blood pressure is 168/85. She clearly has a disabling deficit. In addition, she would be a candidate for thrombectomy as well. So you discussed the risks and benefits about TPA. TPA was given. The patient made a dramatic recovery during infusion. They performed a CT angiogram of the head and neck while the TPA was started. And this showed no large artery occlusion, no leptin-1 occlusion. So at 24 hours, her night stroke scale was 3 with only mild aphasia and mild right hemiparesis. Her TPA was initiated 70 minutes from the stroke onset and 55 minutes from arrival to the door. So here's some facts about stroke. Stroke is the #1 cause of disability in the United States. There's no need to give full dose anticoagulation to an acute stroke, regardless of the etiology. Even if they have AFib, you don't say, oh, let's give them Lovenox. Because, again, that area of brain is susceptible to hemorrhagic transformation. So 1 to 2% of patients can develop angioedema from the IV TPA. Typically, they are on an ACE inhibitor or angiotensin receptor blocker. I've actually never seen someone develop it that wasn't on one of those medicines. And if they do develop that, you give them Benadryl and Pepsid, as well as Solumedrol. I wouldn't consider it, I would just give it. So if they start to develop tongue swelling, you want to give this stuff quickly because you don't want to have to intubate somebody that just received IV TPA. Understand that, finding the cause of strokes is sometimes very difficult. You would think patients that are 35 years old and present with a stroke and are healthy, we would find these bizarre causes easily. But actually, a lot of times their stroke workups are negative, and it's unclear why they had the stroke. Those patients, I do have a low threshold for putting on anticoagulation, however, because I usually suspect that they have a hypercoagulable disorder that we haven't found yet. Or it's cardioembolic, and both of those things you treat with anticoagulation. All right, any questions about stroke or TPA? Myasthenia gravis. Did anyone talk about this during neurology? Myasthenia? Yeah. It's a neuromuscular condition. It's usually an autoimmune condition, but can be congenital, and there's other causes to it, but autoimmune is what we're going to focus on today. This is a picture of somebody with myasthenia who in the morning time, their eyes are nice and open, and then by the nighttime, in the evening, they're droopy, and grandma's just tired. So, so this is the most common disease of neuromuscular transmission. So the hallmark of the syndrome is fluctuating degree of variable combination of weakness in ocular, bulbar, limb, and respiratory muscles. So bulbar, so ocular, what do I mean by that? So ptosis and double vision. So muscles control eye movement, and these are small muscles. Myasthenia gravis typically affects small muscles first because it depletes acetylcholine. So bulbar is swallowing, jaw control, tongue weakness. Their voice will become nasally and weak. Those are bulbar. And limb is, typically proximal weakness that is fatigable. And then respiratory muscles is kind of a restrictive lung syndrome, so trouble, orthopnea, trouble breathing, dyspnea on exertion. So that by itself is very nonspecific. So it's immune system mediated. We're talking about autoimmune myasthenia gravis. It's a postsynaptic disorder, and that affects the acetylcholine receptor. Myasthenia gravis occurs at any age, but there tends to be a bimodal distribution to the age of onset with an early peak in the second and third decades. And this is typically females, it's much more common in. And then in a late peak in the 6th to 8th decade with a male predominance. So the support group, it's old men and young women. Clinical features, fluctuating muscle weakness and fatigue. And by fatigue, I mean fatigable muscle weakness, not I'm just tired. So there's that. And then, so presenting symptoms, ocular is one of the more common presenting things. So double vision, ptosis, you do the sustained up gaze, and they'll develop kind of a disconjugate gaze or a skew deviation from the myasthenia, actually, where one eye will be higher than the other. And they'll have double vision. So if they're complaining of intermittent double vision, you can check that by having them just stare up at your finger and see if they develop double. And then you try and establish if it's vertical or horizontal diplopia. Bulbar symptoms, like we talked about dysarthria, it's usually kind of a nasal quality speech. They'll have trouble swallowing, and they'll develop jaw weakness, and sometimes they'll develop what's called jaw drop. They just can't close their mouth and they're just drooling. Or they get tired and have more difficulty chewing food the more they eat. Facial weakness, so they'll develop droopiness of the eyelids, but they can develop actual facial weakness where they can't close their eyes tight, they can't close their lips tight, and their mouth is just kind of open all the time. Orbicularis oculi, again, we talked about that. Most myasthenia patients will have some orbicularis oculi weakness. Limb weakness, less than 5%, but if they develop crisis, they certainly commonly have this. Extensor neck weakness, so sometimes these patients, because we have to hold our head up all day and our head is heavy, they'll develop ptosis of their head, where their head will drop and they can't lift their head up and they just walk around like this. And then when they wake up in the morning, it's better. There's some other conditions that can cause that as well. ALS is MND, motor neuron disease, inflammatory myopathies, and paraspinous myopathy. So isolated respiratory weakness is uncommon, and again, there's other neuromuscular conditions that can do this. Motor neuron disease, ALS, would be the more common condition. Acid maltase deficiency, which is Pompe's. And then polymyositis, which is an autoimmune muscle disease. And again, isolated distal weakness is uncommon, that can happen. Usually they'll kind of have extensor weakness. But you'll think of other neurological conditions as well with that. So the diagnosis, history and physical exam. Some it's difficult to diagnose. You can do these bedside tests. The ice pack, I don't usually do this one, but a lot of neuro-ophthalmologists like to do it. In the ER, we'll give what's called Tensilon, which is an acetylcholine esterase inhibitor, so it increases the amount of acetylcholine at the neuromuscular junction rather quickly. It's an IV drug. And if they have a definable deficit and you're suspecting myasthenia, you can do this and that will rapidly improve. We typically like to do a double blind, one in the ER where we don't actually know which one they're getting, if they're getting a placebo or the Tensilon, so we can be a little more objective with the medicine. The problem is when you give Tensilon, it kind of can drop their heart rate quickly, as well as cause a lot of nausea and abdominal discomfort. But we actually did a test on the lady yesterday. And again, their double vision improves rapidly, and their ptosis will improve. Serological testing, so acetylcholine receptor binding antibody is the test you send out. It takes, a week or so to get back. However, the MuSK antibody is even a more specific syndrome. In a rare autoimmune cause of myasthenia, the more common is the acetylcholine receptor antibody. MuSK usually present a little differently. Again, they're usually females in their 30s. For some reason, more common in African American women. And they typically have more bulbar presentations rather than ocular and respiratory, and then the head drop is a common presentation with them as well. So it's still, wrote it. So the MuSK is still myasthenia gravis, it's just a different form, and the treatment is a little different. Symptomatic treatment of myasthenia is the Mestinon pyridostigmine. This is kind of the long-acting version of that Tensilon. It increases the amount of acetylcholine at the neuromuscular junction. And this helps with the symptoms. It's kind of like nitroglycerin for myasthenia. The onset is typically within 30 minutes orally, and it peaks at about 2 hours. You got to be careful with cholinergic crisis. You don't give people more than 800 milligrams of Mestinon a day. Usually the usual dose is 60 milligrams 4 to 5 times a day. These are the immune-mediated therapies, the chronic therapies of myasthenia gravis. So prednisone takes about 2 to 3 weeks to really start working, and the peak efficacy is about 5 to 6 months. That's kind of the standard treatment. Imuran is what we call a steroid-sparing agent, which is the azathioprine. We typically start patients with autoimmune myasthenia on the idea of getting them down to the lowest dose of prednisone possible, given all the side effects associated with prednisone. Again, azathioprine is not going to work immediately. It takes about 12 months to really start kicking in because it's working at the level of DNA. It peaks at about 1 to 2 years of being on it. Cellcept, or mycophenolate mofetil, is another medication. And then cyclosporin, I've never used. Rapid immunotherapies, so these are things that you'll give to people in crisis. So they come in, they can't swallow, they can't eat, they can't breathe, they're weak. These are people that need to be in the hospital. So plasmapheresis, and then, which is plasma exchange, where you take the blood and basically filter off the antibodies. This works rather quickly and quite well. But the more easy treatment is the IVIG, which is intravenous immunoglobulin, which again it's a blood product. It's plasma that is cleaned up, and it's basically just infusing antibodies. We don't know exactly why it works, but the onset of these treatments are usually within 7 days, with their peak effects being about 2 to 3 weeks. But the drugs stay in your system for up to 6 weeks, maybe longer, or the effects of them do. Thymectomy is a treatment that you consider in patients younger than 60 years old. There's a new trial published last year that showed that patients that got thymectomies tended to be on lower doses of steroids and had less relapses. So myasthenia can be a life-threatening illness, but it is very treatable. Respiratory failure, people that can't swallow, those are the people that need to be admitted. So again, the dyspnea worsens when they lie flat. They don't seem to have a heart condition or a lung condition. Severe dysphagia, trouble swallowing, clearing secretions. Their voices are very nasal. Their speech is very hypophonic because of their respiratory weakness. And then you can measure vital capacity, and theirs will be reduced. Typically, you'll monitor the vital capacity and the negative inspiratory force while they're in the hospital. So you need to keep an eye on this. And at times, these patients have to be intubated, but we try and avoid this. Treatment is the IVIG or plasmapheresis if they're in crisis. Then you'd start them on steroids, but you got to be, you don't usually give them the IVIG or the plasma exchange maybe for a couple of days or a day or so, because occasionally the steroids in a small percentage of patients, and we can't predict which patients, will actually make them initially worse and the patient will go into fulminant respiratory failure and have to be intubated. It may end up with a tracheostomy just because it's going to take them a long time to recover. So patients that have never been on steroids for their myasthenia, you got to be hesitant to start those right away. Typically we'll give 1 or 2 treatments of the IVIG and then start them on high-dose steroids. Now if they're a patient that have been on steroids for a long time, like 10 milligrams, and they've been stable, and then maybe they got some kind of infection and developed an exacerbation of their myasthenia, you can increase the steroids on those patients without worry. So Guillain-Barré syndrome, looks like we're running out of time, is an acute immune-mediated polyneuropathy. It's typically described as the ascending weakness. It's somewhat of a rare condition, but not terribly rare. Is that the next lecture? Okay. So male to female ratio is pretty equal, typically in young adults and older than 55. Here are some classic clinical features. Usually they have symmetric muscle weakness. Most patients will have some paresthesias early in the onset. A lot of times they'll have severe back pain because of the demyelination of the nerve roots. Again, textbook-wise, usually starts in the legs, and that's true. However, it can still start in the face. I've seen people present with, initially they have like a Bell's palsy, and then they develop bilateral facial paralysis. They can develop arm weakness initially. So it's variable depending on the syndrome. Proximal usually rather than distal. Severe quadriplegia, they can become bedbound. These are about 30% of cases. They can develop respiratory failure. Again, these are patients who are going to monitor the vital capacity and the negative inspiratory force. So approximately 30% of Guillain-Barré patients require intubation. Typically, they'll peak over about 7 to 9 days. They'll be at their weakness, though it can be up to even 2 to 3 weeks. They commonly have cranial nerve involvement, usually a cranial nerve 7, but they can have oculomotor weakness, which will overlap with the Miller-Fisher variant of Guillain-Barré. Guillain-Barré is a syndrome, and there's multiple subsets to it. They can have tongue weakness. Again, sensory is usually the initial symptom, but again, it's mainly a motor syndrome, meaning they'll mainly have weakness. Some patients will have significant pain associated with it, neurogenic pain. They typically lose their deep tendon reflexes. Sometimes it takes them a few days to do this. But usually the ankle jerks are the first ones to go, but they'll commonly lose all their reflexes by the time they come to the emergency room. Autonomic dysfunction, they can have certain arrhythmias, they can fluctuate and be very hypertensive and hypotension, so you have to be very cautious on treating them. If they're very sensitive to the medications, they can develop an ileus. Again, it can progress up to 9 days. The most common cause of death in Guillain-Barré are pneumonia, pulmonary embolus, and iatrogenic hypotension, so again, be cautious about putting them on blood pressure medications. Prodrome. A lot of patients with Guillain-Barré will typically have a upper respiratory infection, GI infection part of that. Campylobacter jejuni is a common test question. This is something that happens in Japan. It can predispose to Guillain-Barré. Epstein-Barr virus and HIV as well. You want to do a lumbar puncture on these patients. Usually the protein will be elevated, though it can take a few days to a few weeks for the protein to become elevated, but that's the classic hallmark of the syndrome, is elevated protein, but no significant white blood cells in the CSF. That's called albuminocytologic dissociation. You want to check the ESR and the CRP. Typically it's less than 50. If it's higher, you've got to think about other causes, like vasculitis. You would want to get an EMG neuroconduction study. That helps in prognosis and to make sure you're treating the right syndrome. And then typically we MRI their necks. AIDP is the most common variant. This is acute inflammatory demyelinating polyradiculoneuropathy. AMAN is a rare form in the United States. AMSAN is similar to AMAN but has sensory. AMAN is pure motor, so they don't have the numbness or tingling. Miller-Fisher syndrome is ophthalmoplegia. They have ataxia and areflexia. So that's a specific syndrome. And that same variant can cause Bickerstaff's encephalitis. And then there's multiple other variants of Guillain-Barré. The differential diagnosis, there's a chronic relapsing remitting form of Guillain-Barré called CIDP, chronic inflammatory demyelinating polyneuropathy. You want to check certain vitamin levels, B12, B1, arsenic poisoning, so you'll look at their fingernails and look for mesalines, vasculitis, sarcoid, some other things. Usually these other conditions will have more abnormal CSF and blood work. Certain spinal cord disorders can mimic Guillain-Barré, transverse myelitis, because sometimes in acute spinal cord syndromes they won't have the brisk reflexes initially. Neuromuscular junction disorders, if it's just motor symptoms and no sensory. And then if they have Miller-Fisher, you'd want to think of other brainstem syndromes. Treatment is IVIG and plasmapheresis, very similar to myasthenia. Give 2 grams per kilogram over 2 to 5 days. These are just disease-modifying treatments, meaning they improve time to recovery. They're not a cure. So people may still get worse even though you've given these treatments. It doesn't mean that your treatment really failed. It's just they have a severe disease. DVT prophylaxis is important because, again, a common cause of death is PE. Most people do very well from Guillain-Barré and make a nearly full recovery, but occasionally, these are some prognostic factors for maybe not having as good of a recovery. They have to end up intubated if they're older, or it's rapidly progressive over several days. And relapses can occur approximately up to 10%. All right, I guess we'll stop there.